Happy Hour really came about because of the way the Lynn wanted to sort of replace some of the face-to-face and in-person meetings that we've been holding for over 10 years now, and realising that with COVID, we wanted to maintain a way that we could share the adaptive learning. And for those of you who aren't familiar with the HAPPI report, the Housing Our Ageing Population Panel for Innovation report that Lord Best chaired, we are looking at issues really across the ageing profile, and looking particularly around older adults and people with disabilities, around their housing circumstances through our series of Happy Hours. And this is the penultimate one, and they've been really well received and a really good way for us to maintain our networking and sharing, learning and good practice. Today's session, Health Starts at Home. The observant of you will know that that's also the title of the government's Memorandum of Understanding of Health, Housing and Social Care, a really important document that the Housing Lynn signed up to a few years back, which shows that there is a need at both at a high level but also locally to work collaboratively to support integration and integrated approaches to supporting people live well, whatever their housing setting. And so the Department of Health and Social Care, MHCLG, Homes England and a number of other bodies, trade and professional bodies, have signed up to this. And we're really keen to use the Happy Hours as a way of sharing the learning, as I was saying. And today's session is very much looking at issues relating to the application of disabled facilities grants, home adaptations, and the role of technology to support people live with more independence, or indeed support them transfer care and support as appropriate, perhaps after a hospital admission or a crisis intervention. And we're going to hear from three excellent speakers on that. For those of you who are also expecting to hear from Safia Iqbal from Derby City Council, I'm afraid she isn't able to join us this afternoon, but we will post up a copy of their work in Derby, in particularly the Healthy Homes project that they have to support people and prevent people being admitted back into hospital as well following discharge. So again, an interesting project that the Lynn has focused on, but she isn't going to join us today. So instead, we have Becky Walker, the Home Improvement Agency Manager for Oxford City Council, who's written a lovely little blog for us some months back now, it feels, Becky, but thank you very much for joining us. We have Zilla Moore, the Marketing Director from Tunstall Healthcare. Thanks so much for joining us, Tunstall and Zilla. We're going to look at issues around the winter pressures again, and how the NHS can look at this in relation to the care tech. And last but not least, another Walker, this time Lauren Walker, the Professional Advisor on Housing at the Royal College of Occupational Therapists, and she's going to talk about the work that really was pivotal in terms of thinking about adaptations without delay. But without further ado, let me hand over to Becky.
Thank you very much. So if we can move on to the next slide, that's just the first one. So I'm Becky Walker, I'm from Oxford City Home Improvement Agency, and we're a very small home improvement agency that's based in a district council, Oxford City Council level, and just going to talk about some of the work that we do to help older and disabled people and support them living in their own homes. So home improvement agencies, there's one across the whole country. Most of the country's got home improvement agencies, a few areas that haven't, but generally they're there to help older disabled people live independently in their homes for as long as possible. And our main aim is to help people repair and adapt their homes so that they can stay there for as long as possible, and to offer all sorts of grants and things. And this is a picture of our team, which includes a couple of occupational therapists that we have in-house in our agency as well. And as you can probably imagine, this was taken pre-COVID because we're all standing quite close together, but that is a picture of all of us all together. So this is a sort of a summary of what we do. We've actually got quite a comprehensive RO policy, or regulatory reform order policy, which outlines all the things that we can do with our disabled facility grant funding. So we get disabled facility grant funding from the Better Care Fund, and you can just use it to offer disabled facility grants, but you can also, as a lot of people know, write a policy that allows you to do more innovative things in your particular area to meet the needs that you've got. So what we've done is we've written a sort of 90-page RO document that gives all the different grants and assistance we can do to help people in Oxford City. But what we didn't want to do is send that out to people and market it and say, you know, if you want this particular grant, you have to phone up and ask for an ERG and say, can I please apply for an ERG because I meet this criteria and that criteria, and it just gets really complicated. So what we've tried to do is split it into 4 main areas. So we've got the leaflets there you can see in front of you. So the orange one is helping people adapt their homes. So it's making it more suitable for them to live there. And that could be things like level access showers or stair lifts or bedroom, bathroom extensions, any sort of adaptation that makes it easier for people to live there. And then we've got a heating leaflet, and that's to help people with all different types of heating. So we help people with boiler servicing, boiler repairs, boiler replacements, and we also give out lots of temporary heating. So if we come across somebody that hasn't got any heating, we've got temporary heating we can give out. We've got blankets, we've got hot water bottles, all sorts of things basically to keep people warm. And then there's our repairs and assistance, and that's helping people with sort of major repairs that they've got in their houses. So it could be they've got problems with their electrics or their walls or their ceilings, and they've got roof leaks, all those sort of major repairs that people have in their homes quite often. And then on the far right, we've got a small repairs person. So that's a handy person type service, which is a subsidised rate. So people can phone up and ask for the handy person service. It's at £20 an hour, so it's quite low. And they go and do little odd jobs around people's homes. So the more observant of you have probably noticed that there's actually 5 leaflets. And the reason that is because we did a specific leaflet for children, because a lot of our leaflets are aimed at disabled people, but mainly the older age group. So there's lots of pictures of older people, and we wanted a specific leaflet that reached out to disabled children and their families, so that it was something that meant that specifically for them, to show them the sort of help we could do to them. So we've also got the small repairs leaflet. And the other thing that we do as well is we offer a specific grant called a Safe and Secure grant. Somebody's not turned their microphone off. So it's a Safe and Secure grant, and it's specifically to help people either stop them going into hospital, so it's a prevention service, or to enable them to get out of hospital. So it's a specific grant, very small grant to help people, homeowners get financial assistance to reduce risks and accidents, really. And all of these services carried on all throughout the COVID period, so all through the lockdown. So we didn't stop at all. We had some very, very good contractors that worked all the way through. Obviously, we had to change our procedures a bit to keep people safe, but we were doing adaptations, help with heating, repairs, and everything all the way through the process. Next slide, please. Right, so you probably all remember back in March, NHS decided that they were going to reconfigure hospital service and try and get 33,000 people out of hospital to treat possible potential coronavirus patients. So there was a huge drive at that period to try and get as many people as possible out of hospital. So we were already trying to do a little bit to try and help with hospital discharge, but it was really increasing at that point. And a lot of routine operations are also being cancelled as well. Obviously, that's still going on now, but we knew, because we work quite closely with our hospital partners, that there's a lot of housing issues that specifically stopped people from being discharged from hospital. So we wanted to help with this drive to get as many people out of hospital as possible. So what we did is we got emergency agreement to increase our safe and secure grant for a temporary basis to enable more people to get out of hospital. And we set up a grant for, it was up to £2,000 per household. It was a non-means tested grant, so it's available to everybody. And we made the criteria for this grant as simple and as the criteria and the application process as simple as possible, so it could be a really, really quick process to get people out of hospital, because we wanted to make sure that obviously they could get out as quickly as possible and they weren't exposed to unnecessary risks and things. Next slide, please. We also, Oxford City is that little white bit in the middle there. So although we've got an awful lot of people in our own area, a lot of the hospitals that we deal with cross a lot of county borders. So what we didn't want to do is set up this amazing scheme to help people out of hospitals, and then the hospitals had to sit there and think, well, does this person live in Oxford City or do they live in one of the other areas? So we coordinated with all our different districts within Oxfordshire to make sure that they were offering a similar sort of service, not exactly the same, but a similar service. So it was one route for all the hospitals to contact to actually access help to get people out of hospital quickly. We also set up at that point, we've got an internal contractor, Oxford Direct Services, which does all the council house stock within our council. And we set them up specifically. They'd also got reduced staffing due to COVID. There's a lot of people working at home and everything else. But we got agreement that they would prioritise this work for hospitals. So they set up a specific team that would do all this work for us. And we got agreement with them that they would go out generally the same day to do work. So if we got an emergency request for something, they would go out the same day and try and rectify it for people. Next slide, please. So at that point, then we wanted to make sure that everybody was aware that we were doing all this work to help people get out of hospital. So we marketed this new safe and secure grant to all the hospitals in Oxfordshire, contacted adult social services, the GP surgeries and all the health professionals that we dealt with. Also in Oxford at that time, they set up things called hubs, which were all set in the community of Oxford, and you could go into it, so they're all set where people actually lived, and you could pop in and just ask for help. So we contacted all of those as well to make sure they were aware of all these grants as well. We heavily really marketed all the grants. We emailed all of our contacts that we had to tell them about it and give them a route to actually refer people in. And you can see this is a very successful partnership we've had with the John Radcliffe Hospital, not hotel, and they very kindly allowed us to have a permanent stand in their hospital. So they let us have a table and a stand there, which we've got up all the time. And they also let us put leaflets absolutely everywhere, so you can see all the pictures there. They're showing, we put leaflets on all the posters and on notice boards, everywhere we could find a little space we put on some of our leaflets. And we also, the middle one there is next to the taxis, so that's where people are waiting for buses and taxis to take them home. We've got leaflets there as well, so they allowed us to market everywhere. Next slide, please. And then we also utilised social media as well. So we put adverts and little stories out on Facebook. We put things out on Twitter. The one in the middle there is one of our dementia clients, which very kindly did a little video for us, just explaining what difference the assistance that we did helped to them. We did an awful lot of work just trying to tell everybody, because there's no point having all this assistance and help out there if nobody knows to send in for it. So next slide, please. So this is just an example of some of the work we did. So we got an urgent request from the John Radcliffe Hospital, and this particular person needed to go home, but they weren't able to go home because they had no hot water and no central heating, and they also had to do a deep clean of the house before the person could go back. So we arranged with our gas safe engineer to go out with social services the same day and inspect to see if there was anything we could do with the boiler to repair it. but when we got there, it had actually been condemned and it had a do not use sticker on it, so we couldn't use it at all. And in that case, we used a combination of our safe and secure funding and a discretionary DFG funding. And we took the old condemned boiler away and fitted a brand new combi boiler in its place. And the process to completion took, it was only 4 days in the end. We managed to get a boiler quite quickly, fitted it all and got him deep clean done. And then he was discharged back from hospital. But without that, he wouldn't have been able to go home at all. Next slide, please. So that's just a picture of the boiler after, and you can see that the care coordinator at the JR was really pleased because we managed to sort it out really quickly. They just referred it through to us. We sorted out everything. We organised the gas safe person. We went there, helped them do the deep clean. We did everything to get them out. So it made a huge difference. So, next one. And this is just explaining, so since the beginning of the COVID pandemic, we've roughly undertaken 130 safe and secure grants. That was last month, at total cost of 49,000. And you can see there the average cost of the job was about £376. So although we've increased the limit to £2,000, most of the work that we do for safe and secure is really, really small amounts of money. And we all know how much it costs to keep somebody in hospital. Not only the cost of trying to get people out to release the pressure on the NHS and to release beds, but also the cost of actually keeping people in hospital is really high. But the type of interventions that we do to get people out is quite small. It's only 376, as I said. So the sort of things we've been doing is we've been purchasing microwaves for people. So that somebody has gone into hospital, before they went into hospital, they might have been able to cook for themselves. When they've gone out of hospital, they need carers to come in and warm up food, but they haven't got a microwave. Seems really simple, but if you haven't got a microwave, you can't go home. So that could be like weeks and weeks of trying to work out who's going to pay for this microwave. So we've just bought them, £20–30. We've also bought bedding for somebody to come home from hospital, and we've also done things like paid for new locks. So if somebody's been taken into hospital by an ambulance and they've had to break down the door, sometimes they just have to board it up, and then we've managed to sort out the door for them and get them new locks so they can actually get back in and get home. We also made over 765, sorry, can we go back one? 765 welfare checks. So we went through our entire database of clients for the last year or two, and we actually phoned them all up individually just to make sure that they were all okay. They all had help. Most people were on the government list, but there was quite a few people who had been missed off. So we went through everybody and just made sure that they had access to food. They had somebody picking up their medicines, and then if they didn't, we referred them through to the hubs, and they organised to take food round and to get the medicine organised. And we're still doing that for a few people now. Next one, please. So that's just some feedback that we've got from all the different people we've been dealing with. I'm not going to read them all out because you can read them all yourselves. But it's been really well appreciated, and people are really, really happy. Then what I wanted to point out to you is the one at the bottom. So that was a lady, a disabled lady, who'd got a broken toilet, and she'd been using a bucket for 6 weeks just to be able to flush her toilet. And she hadn't been able to get anybody to come out and mend it, because obviously there wasn't a lot of people around at those stages that could do it. So we managed to organise somebody to come out the same day, mend a toilet. It's a really simple thing, just a flush. But she said, you know, thanks very much. It's already saved me from bothering my GP so much, and I was worried about going into hospital, and that's not happened. Next one, please. So we also fit an awful lot of key safes, and key safes are really important to get people out of hospital, because very often when somebody goes out of hospital, they also go out with a care package, and the carer needs an access to be able to get into the property, and the person can't always get to the door. So they often need a little key safe, which keeps keys safe. Key safe, yeah, you know what I mean. So it's just a little box on the door, people put the keys in it, they have the code and they can get in. It seems like a really simple thing, but there's been a lot of studies that say that a key safe estimates to save the NHS approximately 7 bed days. So we've done this calculation and said last year we actually installed 452 key safes, which we estimate saved the NHS 3,164 bed days. And working that out on the calculation that they gave us, that's a saving of £1.145 million. So it's just a small little thing. It doesn't seem really important. It's just a key safe, but it can be really, really important to get somebody out of hospital. Next one, please. So also we come across a lot of bigger repairs. So I've been talking about the smaller things that people needed. That's my phone. To get their house sorted out. And we also come across a lot of really big repairs, very vulnerable older and disabled people that need major structural repairs to their house that all cause really big health impacts to them as well. And facing a home repair can be really daunting to some people, and they don't really know who they can trust and who they can get to organise the work. So having the HIA there really sort of provides services they can trust. So the two things that we offer is a flexible home improvement loan, and you can see that's a loan provided to anybody age 60 and over who needs major repairs or adaptations doing to their house. And we've also got a grant, which is an essential repair grant, and that's to low-income homeowners who again need structural repairs doing to their homes. So last year we spent £392,000 on flexible home improvement loans, and also £96,000 on essential repairs. So we've done a lot of work with those as well. Next slide, please. So this is just an example of a typical repair that we get asked to do. So this particular person was just somebody that came into our agency and asked for us to do a small handy person job. So the small job they wanted doing, our handy person went round, found this, and it's generally somebody that's been living there for a very, very long time. They've got older and disabled, and work's just got on top of them, and they just haven't got any money to keep on top of those little jobs, and their house just runs away with them, really. So this is somebody that's came across to us. We helped them apply for a flexible home loan on their property, and we organised all the contractors to do the work to help them sort it out. And then if we go to the next slide. The magic wand. So that's their kitchen after. So we've managed to sort out their little lean-to on the back, build them an extension. You can see they've got a brand new boiler in there. And if you can just see the little picture at the back, we've also, you can see, fitted a level access shower in them as well. So they've got a shower adaptation at the back. So that particular person didn't have a toilet. But that can happen quite a lot. So we're also, we've been working with Dementia Oxfordshire, because we found that there was a lot of people coming along who had dementia. There are minor works available from social services that do little odd things, but there's a lot of things that people with dementia that need, that very low cost things that make a huge difference to them, but they're not covered by minor works. So we set up a project with Dementia Oxfordshire just to help them give these services. So we've created a referral pathway that's really, really simple. So the dementia advisors go around to see somebody after they've been diagnosed, and they discuss with them what sort of things would be really important to them to help them keep them safe and make it easier for them. And these are just a few things that we do. So there's big button telephone, there's the alarm clock, there's a whiteboard at the bottom, which you probably can't quite see, but that's really simple things. So for example, a carer can say, don't worry, I've just gone out to the shops, I'll be back in 5 minutes. or you're getting picked up today at 10 o'clock, those sort of things. So little messages, it can be really, really helpful. The signage there, you can see those. We print those out on laminated sheets, and they can be really, really low cost interventions that make a huge difference to somebody with dementia, because you can just stick it on the door and say, this is where the toilet is, which sounds really simple, but to actually do that for somebody, not everybody's got a laminator in their home, is really, really difficult. So we, the Dementia Oxfordshire, send through referral to us, and we go and fit it generally the same day, and we go and take those things out and fit them. And we have been quite amazed at the amount of people that we've gone round to fit a small intervention, like a sign or something, and we've gone round and then found out that person actually needs a tremendous lot of help. So they might not have any heating, they've got their electrics are shot, they've got leaks coming through the roof, they've got all sorts of things going on, but because they've got all this pressure of dementia or caring for somebody with dementia, they haven't been able to organise it. So we go in, do a small intervention, then we can then help with the bigger things. And then this particular one, this was because a report came out during the COVID pandemic from the Centre for Ageing Better that was basically talking about the difference that music interventions had for people with dementia, and we were really impressed with that report. So we went back to Dementia Oxfordshire and said, was there anything we could do to help with that? And we came across this big button radio. So it's a radio where you can set it specifically to the radio station that particular person likes, and all they have to do is press one button and it comes on with the music, which really helps them, especially in these sort of times where people are living on their own with not many people coming to see them, and helps them out. And yeah, I think that's it. I think the last one's just my details. So if anybody wanted any more information, they can contact me or ask any questions. Thank you.
That was fantastic, and I know that, I don't know if you've managed to look at the chat box, quite a few people saying amazing work, really well done. And I think what you described is a very useful sort of way at a very practical level about both the challenges that people are experiencing, both in terms of post-hospital stay, but also some of the things that build up over years and then get exposed as a result of a crisis. So again, very helpful conversation there. Thank you very, very much. And I will post your guest blog in the chat box in a moment. In the meantime, just before we move on to Zero, there are a couple of little questions, and if you wouldn't mind, can I just, I don't know if you can sort of scroll or have a look. There's one from Clive, I think, I saw earlier. Clive Cook, yes. Becky, can you give a quick overview of how all this is funded, please? Is there a quick...
Yeah, there's
you could just sort of share with us?
It's never a quick answer, is it? But basically, the most of the funding comes from disabled facility grant funding, which comes from the Better Care Fund, which is given to district and county councils. And you can just say, right, all I'm going to do with this is I'm going to give it for disabled facility grants, which is quite specifically for level access showers, stairlifts, those type of things. But you can, and you are actively encouraged to write a regulatory reform order policy in the council that allows you to do almost anything really, well, within reason, that meets the aims of the Better Care Fund. So as long as it helps people reduce falls, stop people going into hospital, helps them come out of hospital, and in an innovative way, you're allowed to use that funding as long as it's written down in a policy and consulted, obviously. So we did that. We came up with some ideas, went out consultation, wrote a policy. So a lot of it's funded by that. A lot of our heating work, we apply for different charities and things. So the boiler service is paid for by the Gas Safe charity. Some of it comes from Oxford City Council itself, which puts money up towards that. The flexible loans was some money that came from, I believe it was the government told the banks off for doing something from the conduct authority, and some money got put together and a charity was put together, and a load of local authorities got together and put some money in and basically set up the Flexible Home Improvement Loan Company. It is in its essence an equity release product, but it's backed by the council. So it's a very safe and well-regulated flexible home loan. And the idea is that people in properties that may be worth a lot of money, but they haven't got any income coming in, we can release money from that property and help them release money to do work. So some of it comes from that as well. So it's a variety of either disabled facility grant funding, charity funding, money that comes from the council, or a loan on somebody's property.
If I remember rightly, some of this you've captured on the website as well, and you've got quite an extensive website. So again, please do, colleagues on the chat box and on this happy hour, please do go on to, oh, there it is, oxford.gov.uk/HIA. So there'll be more details there. But for now, can I just thank you very much? That's really good.
Thank you.
Answer a quick question from, I think, Jamie. I just saw, yes, the slides will be shared. For those of you who've joined us late, this session is being recorded, and all the slides from all our 3 speakers will be available and sent out post this event, and also on our Housing Lynn events page. For those of you who joined us late and were expecting Safia, I'm afraid she's unable to join us, but I have put up the Housing Lynn case study on the Derby Housing Derby's Healthy Housing Hub on the chat box as well. But without further ado, can I really welcome Zilla Moore from Tunstall, and I think you're already on screen there, Zilla. So
thank you, Jeremy. So I've been asked to run through some of the technology that Tunstall manufacture and deploy to assist people at home, and really talk about how that was used during and adapted during the last COVID crisis, and what we anticipate the needs are going to be as we move into the winter, with all of the challenges that's going to present. So as the first slide alludes to, I think the general thought is that this is going to be a pretty challenging winter from everybody, but potentially for those who are already vulnerable, it's going to be even more difficult and going to put a huge amount of pressure on the NHS. So we can move on to the next slide, please. So this was actually based on some reports that were published at the end of the summer, and what our medical experts anticipated to be the kind of challenges waiting for us this winter. So, you know, there was a huge anticipation of a rise in COVID cases, which we are starting to see. There's absolutely no doubt about it. And whilst we haven't seen the NHS becoming as overloaded as we saw back in the spring, it's a very worrying scenario to see the number of cases going up, which will of course cause a lot of disruption in the NHS. So there is a real emphasis on trying to empty beds as fast as possible and discharge people from the NHS to make room for those potential COVID patients. That causes a challenge in itself, because you still have all of the standard winter pressures that come along every year, as well as the COVID pandemic, and you still need to be concerned about how you manage patients with their conditions, whether those are short-term and acute or long-term conditions. So there's a lot to consider, and then on top of that, you've got the general winter flu season anyway, and the general problems that the NHS sees every winter. So from a kind of care, from a healthcare perspective, the anticipation was this was going to be a pretty challenging winter. So the government did a lot to try and prepare for this. So everything we were reading in the summer was we need to get ready, we need to prepare, and this is where technology has advantages, because it is actually quite flexible and deployed and easily deployed in a lot of scenarios. So if we could move on to the next slide, I think that the next slide is just going to illustrate even more what I've just discussed. So if you think about it, you've got a whole bunch of people with long-term conditions who normally might be having hospital stays in any normal winter. They can account for a huge amount of bed days in hospitals. People with your kind of diabetes, your heart failure, COPD, they take a huge amount of NHS resources. And on top of all of that, there's an association of mental health challenges for those patients because they have long-term conditions. So that's a consequence of their healthcare in general and their state of health in general. When you add to that the stress of COVID, and you add that to the potential isolation that comes with being a shielded population or being in a state of lockdown, then that's a real challenge. You also have this scenario of a lot of people in care homes, which can have a huge in any normal year has a huge impact on emergency services. And at the same time, the consideration has to be around how do you protect people in care homes, given what happened in the spring. You add on to that, so that's a normal year for the NHS. You add on to that the extra pressure of COVID. So, higher hospitalisation, having to worry about those vulnerable patients, having to cancel routine appointments, and how do you manage your routine healthcare services when you're also trying to take care and prepare for a pandemic. All of the additional stress that causes for the patients and the staff, and then the higher risk of hospitalisation. Overlaid on that, you've also got the general challenges of a winter, and you've also got all of the normal conditions that come with a winter challenge like norovirus. And then we're also starting to see the effects of the first wave of the pandemic in terms of that long COVID. So it's almost a perfect storm, maybe not the right word to use, for the NHS in trying to juggle all of these. So one of the big things we've been looking at is how do we support the NHS and how do we support hospital discharge more effectively, whilst at the same time recognising that you can't just throw people at hospital. Exactly as Becky was eloquently taking us through, there's a whole list of considerations as to whether somebody can be discharged. And then once they have been discharged, how can technology support them in their home, support them while they're in lockdown potentially, but also support them with their long-term health conditions. So if we can have the next slide, please. So the government's recognised that there's been a huge fund put in place, which is available to CCGs and the NHS, although it often involves the social care, having to commission the services to really try and get people out of hospital and support their recovery for a 6-week period once they've been discharged from hospitals. And actually, if you look at the discharge requirements or the discharge recommendations, they're basically saying you need to expand the use of telecare and telehealth where possible. So from a telecare perspective, we definitely saw during the pandemic a huge increased demand for our standard telecare products. So the alarm hubs that we put into independent living homes, into people's homes, whether that was the digital version or the analog versions, we saw a huge uptake in that and a huge demand for some of our more mobile solutions to help people in a short term. What we also saw was a big increased demand for our health monitoring solutions as well. And I think most of the industry who provide health monitoring solutions saw a huge demand. And that ranged from just being able to do GP appointments via things like via Zoom or Microsoft Teams. So the Microsoft very generously deployed Microsoft Teams across the whole of the NHS. You saw things like Attend Anywhere being deployed across Scotland to really support video conferencing and remote GP appointments. That's only part of the solution, though. So how do you support people and how do you engage people when they're potentially isolated at home with a long-term health condition, and also be mindful of their mental health? So we come on to the next slide, please. So this is where telehealth probably has come into its own across the industry. So basically telehealth, and when I'm talking about telehealth, I'm really focusing on remote patient monitoring. So this allows physicians to monitor their patients remotely using app-based technology or web-based technology. And it's been around for a long time, which I'll talk about on the next slide. But, sorry, a bit quick for me there. And it is associated with improving patient outcomes, not necessarily just because they've been monitored at home, because it also engages the patients in their own healthcare, because they have routine tasks that they have to perform in order to be part of the monitoring service. So it does definitely improve patient engagement. it also allows monitoring of at-risk communities. So traditionally, it's been used for long-term conditions like COPD, heart failure, diabetes, but there's increasing uses of it in other areas, looking at obesity, for example, looking at eating disorders, which I'll talk about in a bit. So we've definitely seen a huge uptake in demand for this, not just in Tunstall, right across the industry. It does improve outcomes. It also drives efficiency. So in a normal pre-COVID world, it would allow healthcare professionals to manage their patient cohort more efficiently by allowing them to focus their efforts on the patients who needed it most, and by engaging the patients in their own healthcare. During COVID, it's allowed physicians to be able to monitor those patients without having to physically see them enter patients' homes or enter care homes with the risk of cross-infection. So it's maintained a continuity of care, but without having to put the risk of infection in place. So if we could go on to the next slide, just to kind of give an overview of the evidence for remote patient monitoring. So it's been around for quite a long time, and it's actually quite widely adopted in other countries. Canada really widely adopts this. The Nordics are big proponents of it. I think the UK definitely lags behind when it comes to telehealth deployment. So basically, right from back in 2008, there were studies being done, and it tended to be in the big three chronic disease areas. There was a big trial conducted called the Whole System Demonstrator Program, which was right at the beginning of telecare, when telecare was probably in its infancy. So it looks quite different now because technology's evolved quite a lot. But they looked at COPD, diabetes, and chronic heart disease across a whole bunch of different sites, and it was a multi-center randomized clinical trial. It didn't meet its primary endpoints around cost effectiveness. That was possibly because the equipment was very different to what it is now, so it was probably a lot more expensive than what you'd see with telecare deployments now. But it did show substantially reduced mortality. It did reduce the number of hospitalizations, and it did reduce the time in A&E. And I would say that since then, the technology has moved on leaps and bounds. And because people's own personal technologies now become a lot more advanced, it's a lot easier to deploy this kind of technology. So again, going right up until recently, there's increasing evidence to show that it definitely upgrades models of care. It engages patients more. You get clinical and economic benefits. You're making better use of technology, increases patient knowledge and self-management. And definitely minimized exposure to COVID during the actual pandemic. So the evidence is definitely building. I think one of the challenges for any company making this kind of product or solution is we're not big pharma. So to run randomized clinical trials is probably beyond the grasp of most smaller and innovative tech companies, and there are a lot out there. So really it's looking at how do we partner with our customers to drive observational studies and real world evidence that can help build and help change the attitude towards telehealth. COVID, probably one of the good things, if there's anything good came out of COVID, it has opened the eyes of the NHS and healthcare practitioners to the potential of technology like this. So I don't think that will go away just because the virus. Hopefully we get a solution to that in the next 12 months, but I don't think it will change people's perception now they've seen what technology can do. And I think it's important that we position this technology as an adjunct to that clinical human interaction. This is never going to replace what a physician can do, or a physician's interaction with their patients, or a healthcare professional interacting with the patient and their families. It's another tool in their armory to help them support the long-term management of these patients. So if we could jump onto the next page. So how does it work? Well, I can definitely talk about how the Tunstall system works. So at the heart of our remote patient monitoring solution is a web-based portal called Triage Manager. And that's the portal that the physicians would interact with. So that allows them to manage their cohort of patients. And it has a risk stratification tool built into it. So it will risk stratify the patients based on their current clinical need, so that the physicians can then deploy the resources where it's needed most. And the way it does the risk stratification is it takes input from from remote devices, and those devices can either be My Mobile, which is an app that sits on a smartphone, and it also Bluetooth information from a bunch of smart devices like blood pressure monitors or weighing scales. So patients can record their vital signs on a regular basis, and they also answer several questionnaires about their general health and general well-being. If they don't have access to the smart devices, they can also take those readings manually and input that into the My Mobile device. And the way the questionnaires are built with the clinicians is that they basically have trigger points. So if a patient is breaching any of the parameters set by their clinical care team, then they'll automatically be triaged in the web-based portal. So the physicians will be able to see somebody who's potentially running a risk, hasn't taken their medication, for example, has consistently demonstrated high blood pressure or high blood glucose levels. If that breaches a clinical parameter, then that patient will flag as a red on our rating scale, on our triage scale, and then the clinical team will know that's a high-risk patient that they need to intervene and contact. And we're rolling out. We are rolling out in the next month or so video conferencing capability with that, so then the clinician would be able to have a direct video conference with the patient as a result of that. On the other side, you can also use a kind of a more multi-user version of this app called My Kiosk, and that tends to be used in communal living or the care home setting, where the care home manager or care home team will have an app based on a tablet, and that will have all of the information of their residents, and then they can provide information about the general well-being and vital signs of their residents. And that's been particularly popular during COVID because it's allowed the clinical team, the GP practices, to still manage and support care homes in their area without having to go and physically visit the care homes to take the vital signs. So in the real height of the pandemic, where there was a real focus on trying to limit cross-infection and protect the residents of care homes, this actually allowed the care homes to be able to provide that information to their clinical teams. And it also was quite interesting that there was a reported increase in satisfaction of the care home workers as well, because they felt that they were really getting involved in their patients' healthcare and they were actually giving additional service, and they felt that they were keeping their patients safe. So it's good for the residents. It was also good for the staff's peace of mind. We talk about our solution being condition agnostic. So it's not just for diabetes, it's not just for heart failure or COPD. It can pretty much deal with any condition where you can measure vital signs and ask questions and set parameters. And that's important to us because we want to help our healthcare professionals manage patients, not diseases. And patients tend to come along with lots of comorbidities. So a patient with heart failure is going to probably experience other symptoms and other conditions as well. And we're all very mindful of the impact of mental health from having a long-term condition. So you can also build in questionnaires into the system that would allow to track a patient's well-being and mental health and be able to intervene if that was breaching any parameters. And we can also push out educational content and direct patients to websites where they can also get more involved in their own management and their own self-care. And we definitely see a general better adoption of the technology and better engagement from the patients in their own conditions and their own healthcare when they're fully engaged in this. So we're looking at how do we improve that. So one of the new features in the new year is to introduce a level of gaming, safe gaming, that rewards patients in the way that a Fitbit would generally reward patients, and allows patients to be able to compare. We've seen with other similar products on the market that when you deploy things like this, that patients actually in care homes can become quite competitive, and they like to compare how they're doing, how many steps they've made, how their healthcare parameters are. So it's definitely about creating that sense of community. And then a couple of case studies, if we move on to the next slide. So this is where we've used it particularly well in the last COVID, or where it's been used to great effect in the last COVID pandemic. Now, this wasn't necessarily about keeping vulnerable people at home, but it was actually, it shows how flexible this kind of technology is. So we had deployed we deployed this solution in Cornwall for a number of years, and it was being successfully used to monitor heart failure patients. But during the pandemic, they had a real challenge in their adolescent eating disorders clinic, because they suddenly had to lock down the clinics, and the young people couldn't access the services that they would. So they were really vulnerable. And there was a real challenge to how do we provide continuity of care for this very vulnerable group when they can't leave home. So we actually deployed this to 34 of their most vulnerable eating disorders patients. So these were young people with things like anorexia nervosa or bulimia, and monitored them over a period of time. So it definitely led to a better patient engagement. It allowed the clinical team to be able to really predict who was going to potentially enter a crisis, and they anticipate that it would have reduced the number of emergency admissions. So the data's still early, we're still collecting it, but so far so good. It's allowed the continuity of care of that service during a pretty difficult time. And even though Cornwall's come out of lockdown, they're still supporting the patients with a combination now of being able to see them and also be able to remote monitor them. So it's taken a bit of pressure off the clinical teams as well. And if we jump on to the next slide. So this is another case study. This one's particularly aimed at care homes. So this was a group of care homes in Bolton who were really worried about cross-infection and being able to monitor their residents during the lockdown crisis. So we deployed this. So I think it was across 34 care homes. We deployed the My Kiosk solution, which is where each care home had a tablet. They had all of their patients' information on that, and they were able to collect all of their vital signs on a regular basis. And then the GP team that was supporting those care homes could log in remotely and see how the patients were doing, who needed an intervention, and just monitor them in general. So they monitored them for their long-term conditions, but they were also monitoring them for COVID conditions as well, to see if there was any breaching of parameters there. And I think the care homes were definitely reassured that they were reducing the chance of cross-infection, but they've also found that it transformed their service, got their staff more engaged, gave their staff a greater sense of job satisfaction at work, and they anticipate that it will definitely improve outcomes. It definitely improved their working practices, and allowed the multidisciplinary teams to be a lot more effective. And they anticipate that this isn't just going to be a COVID thing. They're going to keep this going as a way of providing a more rounded continuity of care that allows them to be continually monitoring these patients. So I think these are two nice examples of how the technology was kind of easily adapted. It took us a couple of weeks to be able to create the specific questionnaires. So in Cornwall, for example, we adapted a specific questionnaire that's used to assess the risk of eating disorders patients, and created the app around that, so it could risk stratify the patients. The same thing with Bolton. We had a COVID questionnaire, but we could also monitor those long-term conditions as well. So the patients were getting a general kind of more holistic view, and I think that's the beauty of this kind of technology. It is a medical device, so it has got a level of rigor and evidence base behind it, and it will be, I think, in the next 6 months, it'll move into Class 2A medical device status. So it's continually building evidence, and I think that's what we need to do really to get this adopted as a kind of routine part of clinical practice. So I would say traditionally there was quite a lot of resistance to this kind of technology in the NHS. I think that's definitely changing because of COVID, and I think NHSX is also driving that agenda. And I think patients are also kind of demanding more. So we're constantly looking at how do we improve the evidence. How do we improve the functionality? How do we improve the access? Not everybody has a smartphone or a smart device, so we do offer a service where we provide that as part of the service as well. And how do we improve the patient experience? So how do we augment this solution with more patient-friendly information and ways patients can actually get more engaged in their own healthcare? And I think that's probably something that technology has an advantage over in being rapidly able to do that. Well, I think that's probably me done as a summary. I don't think I've got any more slides. Yeah,
well, that was a real amazing sort of overview. And as you rightly say, you know, the way technology and digital has really transformed over the last 6 to 8 months, as is ably demonstrated by a number of the projects that you've highlighted there. And I was just minding the picture that Becky showed earlier of the radio. You know, we're going from analog to digital and app technology. And you touched on the whole system demonstrator sites. At that time, I was working in the Department of Health, and I remember some of the challenges just getting fax machine to connect with each other to pass over some of the data and get permissions for doing so. So as you say, 10 years on, it was amazing how we've transformed ourselves. I'm going to suggest we move on now and come back and pull the questions together. Lauren, can I sort of welcome you to the screen, and thank you very much for joining us. For those of you who don't know, Lauren Walker, the Housing Advisor at the Royal College of Occupational Therapy.
Thank you very much, Jeremy, and thanks for having me, and thanks folks for sticking with us. So I'm here to acquaint you all with the Adaptations Without Delay guide, which was actually published over 12 months ago. So it was published in summer 2019, and hopefully some of you may already be familiar with it. But I think it's especially relevant to talk about it now because the framework and the guidance that Adaptations Without Delay presents is particularly valuable in the current climate for services and for professionals who are delivering home adaptations in the face of all the many varied and complex challenges that COVID has presented us with. So the guide was commissioned and published by the Royal College of Occupational Therapists, which is my organisation, and developed for us by Housing Lynn. So Jeremy was very involved, and we're very grateful for that, working alongside 2 occupational therapists. And it's designed to be of use and of relevance to all professionals and organisations involved in the adaptations process. And the reason that we felt the guide was needed was because we know that there are some really very common delays and inefficiencies in the adaptations process that means that service users can be left waiting really quite a long time, and sometimes an unacceptable amount of time, for adaptations that they really need in order to increase their independence and their safety and their quality of life. And we wanted to understand how and why these delays occur, and how we might help services to avoid them. And as you can see on this slide, there was a significant amount of stakeholder engagement that informed the development of the guide across the spectrum of organisations and professionals involved with the adaptations process. And this identified a number of common themes amongst adaptation services. And this isn't all of them, and there are more in the guide, but I think these 3 are particularly pertinent. So one of the findings was that waiting for a social care assessment is often a key factor that delays the delivery of adaptations. And that, in part, is due to a misconception that assessments must be undertaken by occupational therapists in all cases, which just isn't true. A second theme was that the need for an adaptation is typically defined by the type or the cost of the solution, rather than the complexity of the situation that it's seeking to address. So we often talk about major and minor adaptations, and we think of minor adaptations as being quick, low-cost solutions, and major adaptations as being costly and time-consuming works, without actually thinking about the specific circumstances for the member of the public who needs those adaptations. And a third theme which arose was that where adaptation services are working most efficiently, there is a high level of integration and collaboration between the different professionals and organisations involved throughout the process. And I think Becky's service, Becky was talking at the start of the HAPPI Hour, is a real kind of shining example of that. You've obviously got a real kind of close-knit multidisciplinary team, which includes OTs, which I'm thrilled about, and you obviously work in a really robust and collegiate way with lots of different kind of organisations as well. And I think that, I presume you would agree, I'm sure that helps in the delivery of your services and helping things to run smoothly. So we felt with the guide that working in a more integrated and collaborative way when assessing, designing and installing adaptations is really, really important and effective in achieving timely, person-centred outcomes for the end user. Next slide, please. Thank you. So the purpose of the guide, in a real nutshell, is to address the themes and the issues that were identified by the stakeholders through engagement. Most importantly, to ensure that people who require adaptations receive a smooth and efficient service, and also to help adaptation services ensure that they are using their workforce most effectively and making the best use of their time and skills. And we feel that a really effective way of doing that is to reframe how services classify adaptations and to shift away from this notion of major and minor adaptations that is primarily concerned with how expensive and disruptive works are, and instead move towards a model that is much more person-centred and focused on the complexity of the circumstances. Next slide, please. So given the importance that I've mentioned of working in an integrated and a collaborative way, the guide is intended to be of use to all practitioners involved in delivering home adaptations and to the public themselves, because it is very much about shared understanding and cooperation. So although it's developed using an occupational therapy perspective, it's definitely not just for occupational therapists. So hopefully whoever you are and whatever your job is, you will see yourself and your service represented in this list that we've got here, and we very much hope that the guide will be helpful to you. Next slide, please. And as I said at the start, Adaptations Without Delay was published long before any of us had heard the dreaded C word, coronavirus. But the focus of the guide on reducing delays and increasing efficiency is clearly very timely in our current context, where you know, Becky's service seems to be perhaps the exception to the rule, and you know, it's amazing that you've been able to keep going amongst everything that's been going on. But I think lots of adaptation services have needed to suspend some of their work, or to work very differently in order to navigate the lockdown rules and to reduce infection risks as well. And if waiting times were long before COVID hit, I think lots of services are likely to be facing really quite a backlog now, and applying the Adaptations Without Delay framework could be a really effective way of getting waiting lists moving, even if services aren't yet back at full capacity. There's still obviously lots of concern about visiting people in their homes, and minimising the risk of infection for service users and for staff as well. And Adaptations Without Delay can help adaptations teams to reduce the number of different members of staff who need to be involved in a case, and also to think about whether some assessments and recommendations can be made remotely, without a staff member physically needing to visit a person at all. And it's true that applying the principles of Adaptations Without Delay will take some investment of time and some changes of working practices. But any changes that are made now in order to respond to COVID are likely to be fit for purpose in the future too. So you're not investing time and effort on a quick fix just to get through the pandemic, but something that will have real benefits going forward as well. Next slide, please. So my final few slides are all content that is lifted pretty much directly from the guide itself. So I'm not going to go into a huge amount of detail because it's all there for you to read at your leisure in the guide. But just to say that there's lots of supporting information and a really clear framework to help you to consider this shift to processes that are based on complexity rather than cost, and to understand why that will be good for service users, and how it will be really helpful for commissioners and managers to design services that are more collaborative and efficient, and how it will help to make sure that individual practitioners, those who are out, you know, doing the doing, are able to use their time and expertise most effectively. So the table that we've got here on this slide takes an occupational therapy approach to considering complexity. So it starts off very importantly with the person themselves, the people who require the adaptations. And it thinks about the particular activities that they are having difficulty with and the environmental barriers that are preventing them from participating in those activities. And this model, it helps us to shift our thinking from those traditional notions of major and minor adapts, and to recognise that sometimes a structural solution is the best approach to a simple problem. And conversely, sometimes a non-structural solution is part of an approach to a complex problem. So it kind of flips the idea of minor and major on its head, really. So something that would typically be considered as minor, like a grab rail, for example, might be just one solution that is part of a really complex situation where it would be very appropriate for an occupational therapist to be involved and to consider all the various factors that impact on the person's safety and well-being. Whereas on the flip side, a level access shower, which is typically considered as major works, might actually be the solution to a pretty simple problem, which could be specified and designed by a technical officer without any occupational therapy input. Next slide, please. So starting from that point of focusing on complexity rather than cost, the Adaptations Without Delay framework itself is then based around 3 categories of intervention, which map to this pyramid that you can see of care and support needs. And this is designed to help services be more proportionate in their response to adaptation requests, and to ensure that their workforce has the right skills mix within it and is being used in the most appropriate and effective way. And the levels of intervention are categorised as universal, targeted and specialist. And the universal level is the green slice down at the bottom of the pyramid. And here you've got the largest number of people, but with the lowest level of need. So the situation and the solutions are both simple, and they can be met by retail options or basic help to install simple adaptations. So there's no real need for these people to have to wait for any sort of assessment, and an occupational therapist certainly doesn't need to be involved. At the targeted level, which is the orange slice, the situation is still probably simple and straightforward, but some basic guidance and support will be needed to select the best option from a range of standard solutions. So that might be things like stair lifts and showers, level access showers. And these can be provided by and large by support staff with the right level of training, and where support can be made available from an occupational therapist if necessary. Then right at the top of the pyramid, you've got the smallest number of people, but with the greatest care and support needs. So here, the person's situation is complex and it requires a really personalised solution, which could be structural or non-structural, but where direct occupational therapy input is likely to be pretty integral, pretty necessary. And I recognise that this type of model probably feels very new to some of you, but there is lots more information within Adaptations Without Delay itself to help you to kind of pull this apart more and think about exactly what universal, targeted and specialist intervention might look like. So don't be put off if it looks a bit abstract at the moment. There's lots there to help you kind of work it through. Next slide, please. And in the guide, we've got some worked examples which go into more detail, as I've said, about things like the workforce skills and the operational considerations for each level of intervention. So what we have here is a universal intervention, and we have Rita as our case study. And Rita is having difficulty getting on and off her toilet. So she contacts the local handy person service, and arrangements are made to install a grab rail next to her loo. So in terms of workforce, staff need to be able to recognise that this is a simple situation, need to be confident in that, and they need to know what the appropriate options are to address the situation. They need to be able to specify what the equipment should be, where it should go, and they need to understand when a more targeted or specialist intervention might be required. In order to do that operationally, staff need appropriate triaging tools, as well as, very importantly, appropriate training and supervision. And there needs to be clear agreement and understanding across the different agencies involved about who does what, when. So for examples like this, there may be no need for the service user to be visited at home at all, other than for the actual installation. So the assessment and the triaging can take place over the phone potentially, or you could perhaps use video calling or solutions like Tunstall's to ask the service user to show you the relevant parts of their property, which obviously speeds things up. And in terms of COVID, it means that fewer people are being put at risk by needing to have face-to-face contact. Next slide, please. Then, surprise, surprise, we've got our targeted intervention. And this example, we have Robert, and Robert is struggling to use his existing bath equipment. So the Home Improvement Agency conducts a simple assessment with him at home, and it's identified that installing a level access shower will be the best way to enable him to manage his personal hygiene. So that would be the scenario if Robert's needs were simple. But if they were more complex, so if, for example, he had a condition that was likely to deteriorate over time, or if he had lots of different needs, it would be appropriate to get an occupational therapist involved in this case. And again, the staff involved would need the training, the tools and the supervision to assess Robert appropriately and identify the appropriate intervention. And they would also, again, need an awareness of factors that might need further assessment from an occupational therapist. But if it is a simple case, rather than needing a technical officer and an occupational therapist to carry out assessment and specification, the whole thing could be handled by a technical officer. And again, that speeds things up, and it reduces the number of home visits that are needed, which we know are really problematic at the moment due to COVID-19. Next slide, please. So finally, there's the specialist intervention, and this is for an individual with complex needs. So here we have Helen, who has multiple sclerosis, which we know is a complex and progressive condition. So Helen's needs are going to change over time. She's also, in this example, already having difficulty with a range of activities. So there's clearly a need for an expert assessment from an OT here, and for a bespoke solution that will suit her changing needs and personal priorities over time, so now and in the future. And the occupational therapy workforce, along with the rest of the health workforce and care workforce, is extremely stretched at the moment because of COVID. Lots of our staff have been redeployed. Lots of them are working very, very differently. But by freeing up occupational therapists' time from universal and targeted interventions, they are going to have more capacity to assess and support complex service users sooner. And it's really important that the occupational therapists have effective working relationships with their other adaptations colleagues who have the technical expertise, ideally as part of an integrated team, so a team like Becky's, but certainly with a really good mutual understanding of each other's area of expertise and a willingness to collaborate. Next slide. So that's it. That's the whistle stop tour. So hopefully this has kind of whet your appetite. It's given you a taste for how adaptations without delay could be helpful to you and your service users in responding, now in terms of the demands of COVID, but also beyond into the future. So if you haven't seen it before, please do download it. It's free, so there's absolutely no excuse. You can get it directly from Housing Lynn. You can get it from the RCOT website as well. But if you have seen it and you have used it, or if you've seen it and decided not to use it, please let us know. So as I say, this was launched over 12 months ago now, and we were always very keen that we kind of find out what happens next. And that was scuppered for a time by COVID. So we're going through this process much later than we had originally intended to, but we really do want to know how it's being used, if it's effective. If not, why not? Because then hopefully we can do something about it and maybe provide some additional resources. So we've got a survey live at the moment that was launched this week that Housing Lynn are very kindly hosting for us. The link is just there. So if you have the time and the inclination, it really won't take you any more than 5 minutes. So if you've used the guide at all, please do let us know what you thought, the good, the bad and the ugly, essentially. And that will be really, really helpful for us in terms of thinking what any next steps might be. And all feedback is welcome. And my email address is down there as well. So if you wanted to get in touch directly, you'll be very welcome to do so. Thank you very much.
Well, thank you as well. And, you know, as you say, it's out at the moment. We have until the 13th of November to respond. And also, if anybody has used it and wants to share how they've used it and wants to write up any of the practice examples, that may also be helpful for us, Lauren, how we can pull that together and sort of build on the excellent report that's out there already. I'm conscious that you know we're just slightly over. I hope people are happy just to stay for a few more minutes. I know that we've had several people sort of post questions into the chat room. Are there any, Lois? Are there any direct questions?
Hi, Jeremy. Yeah, we've had a couple of questions directly to Zilla. I don't know whether Susanna from NHF, you want to unmute yourself and ask your question yourself, or I'm happy to read it.
Hi, thanks. Yeah, I can do. Thanks for the presentation, Zilla. I was just wondering, you were talking about the NHS requirements and specifically related to care homes, but is there a sense in the NHS that the type of service that you described would be useful in extra care or sheltered housing, which is also for older people, not necessarily CQC registered, but still a similar setup with vulnerable residents?
I don't think we've had any approaches direct, but I know of similar other technologies that have been deployed quite successfully into sheltered accommodation and living. It's slightly different. There was a product that was basically aimed at preventing falls, where it was a wrist-worn device, and it downloaded information into a portal where you could look at potential for falls, and that was quite well adopted in that kind of environment. There's no reason technologically we couldn't deploy it into that environment. I think the key is going to be, is it my kiosk or my mobile? Do we want to give it to the residents on a smartphone, even a very simple smartphone, because then they can manage that themselves? Or do you want it on my kiosk, which I think might be a bit of a challenge if it were from a GDPR and data protection aspect. But certainly if the residents could have it themselves, then there's no issue. The trick's going to be engaging the medical side of it, the GP practices or the community health teams. And that's always been probably the sticky point in the past. Somebody else asked me on the chat is if there was ever resistance from the providers for this kind of technology, and absolutely, I would say this has probably been the biggest challenge for not just for Tunstall, but for anybody trying to deploy this kind of technology. That's sort of changing with COVID, and also we recognise that tech companies aren't always great at engaging with healthcare professionals. I come from a healthcare background in pharma and med devices, and I found my first sort of 5 months in Tunstall quite daunting from a lot of very tech savvy language that I didn't understand. And I think that's also true of a lot of our customers. So we need to speak their language and actually bring it always back to the patient and what they're doing to try and help their patient. So we recognise that, and we're putting together a lot more comprehensive programs to help embed this kind of technology and in the clinical care pathways, and help support and train the operators and the people providing it a lot more, because it won't be sticky otherwise. It won't be adopted as a habit. And also trying to refine our language and focus on patient-friendly and physician-friendly language and endpoints and things they care about, rather than some very technical language, which I think tech companies have a bit of a habit of doing. So from a technology perspective, no reason it couldn't be. Probably more of a how do we mobilise the multidisciplinary teams and how do we get that collaboration together. But interesting, we'd love to explore it.
Yeah, it's a good question, and interestingly, Susanna, I had a conference call yesterday with NHS experts that was talking about their priorities really where there's regulated care at the moment. So again, if in an extra care, obviously there is regulated care and in home care settings, but there's also perhaps a real lack of awareness still about what the housing solution is, and actually what is assisted living, extra care, housing with care, and some of the terminology that they struggle with. So really good question. I think something that NHSX will want to take forward as they get to grips with moving beyond just thinking care homes. And I know that we have Libby and possibly Jean from our Northwest group who may know something a bit more about Bolton around some of that, but a really good question. And any others, Lois?
I haven't seen any others come through, and I know that we are kind of going over time, so unless there's nothing else, I suggest that we do wrap up, unless anyone wants to ask a question.
On that basis, thanks for giving me the nudge to do so. The whole intention today was really to pull together a number of strands, looking at AIDS adaptations, disrepair improvements, technology, the use of disabled facilities grants, because actually things like this are about being person-centered, not just being a solution led by technology or by the equipment itself. And so I think all three speakers have really eloquently described that importance of multidisciplinary people working in teams which actually deliver person-centered outcomes. So can I thank all three of you for three excellent presentations, real stars. If you're interested in these happy hours, we have one more this autumn series that's taking place next Tuesday afternoon, where our Welsh colleagues are looking at the work they've been doing across the field, looking at inclusion and social exclusion, but also looking at things like digital, working closely with tenants in housing associations, from United Welsh Housing Association, for example, right through to thinking about how to design more effectively our homes and our extra care scheme to safeguard risks to infections and spread of COVID. So again, that's taking place next Tuesday, and if you don't get our Housing Link bulletin, do have a look at our website. I'm sure there are still a few places left, and thanks Lois for just posting that up. We then will take a short break for November. But the reason is because we're now working full steam ahead to the Housing Link Virtual Summit, which will take place the week of the 7th of December, taking place across the whole week, 2 sessions a day, looking at everything from AIDS adaptations and building on today's session with Zilla and others on technology, as well as things like looking at accessible housing, adaptable housing, and leadership requirements in our sector. So if you haven't already come across the Housing Link Summit, do book yourself one of the places. We've already got about 500 people, I think, already registered to attend. So it's great to see so many of you already buying into our happy hours. And I think, as Lois is encouraging me to say, last orders, folks. So on behalf of the Housing Link, thanks ever so much, everybody, for your participation, and in particular to Becky, Zilla, and Lauren. Thank you. Bye, everybody.
Thanks, everyone.
Bye, thank you.
Bye.